All right, here we go. This is part 3. This should be the final part. Originally, I said that we were going to do 2 parts, but I ran out of time last time. Giant presentation, so chopped it up into 3. Last one, definitely should get through it today. We left off on slide 80 last time, so we're picking up on slide 81 here. If my computer will work, there we go. Preziquel. These are used for worm infections, so you see all the uses here. Mechanism of action, basically it increases the cell permeability in these worms. So it increases cell permeability, specifically calcium in these worms. And then it causes because of the calcium fluctuation. You probably remember from biochemistry or whatever, calcium's used for muscle contractions, right? So because of this change in permeability, it causes strong contractions and paralysis of the worm. And then that is good because then it allows or causes the worm to detach, the detachment of the suckers from the blood vessels. And then that helps the worms to be dislodged. So kind of gross, but kind of cool, right? So mechanism of action there. But this is a good summary. So basically it just causes the paralysis of a worm and contraction of the worm musculature, and then they are no longer able to suck your blood. No, but they're no longer to stay attached. So that's good. Adverse effects, it's usually well tolerated. People aren't on these really long term. Some of the dosing will just be for a day, depending on the type of infection. Sometimes it's 2 days. It can be up to 14 days or maybe a little bit longer, just depending on the severity of the infection. But usually people aren't on long term. But GI adverse effects, some headache, dizziness, drowsiness. So CNS effects, GI effects. But other than that, no box warnings. Not too bad of a drug as far as adverse effects are concerned. Thiabendazole and mebendazole. So you can lump these two together, very closely related. Again, please note that these are not antifungals, even though they do end in the azole, or so please don't get those confused. These are anti-helmintic, or these are worm medications, or for worm infections, for helminth infections. But mechanism of action, basically, it inhibits the formation of the helminth microtubules. And then it selectively and irreversibly blocks glucose uptake and other nutrients in these worms, and then so it causes the death that way. So a couple different ways. You notice the uses here; they're broken down here on by the different names, but basic take-home point. I mean, read through these, but definitely know that they are for worm infections. Adverse effects, again, not any box warnings to worry about. Mainly, it's going to be GI. GI is going to be the most common. So abdominal pain, diarrhea, flatulence, nausea, vomiting. Other than that, there's, every person's different, but usually pretty well tolerated. These drugs also too aren't typically prescribed for a very long time. Usually it's a few days, 3 days. It may be, they also will do 3 days, and then they'll repeat in 3 weeks if a person's not cured. So they'll, prescribe the mebendazole 3 days, wait 3 weeks, see if it's cleared, and then maybe repeat treatment. But so adverse effects, like I said, just stick to, or rather remember, GI adverse effects. Parental Pemaquin. This one used to be, the brand name for this one was Pin-X, Pin with dash X. So I've heard people call it that. That is no longer made, and so they technically don't have a brand name for this anymore. But you may hear that sometimes, or that's one that I've heard. It was an over-the-counter one that they made, but another worm antimicrobial or anti-helmintic medication. So please note the uses there. And as far as mechanism of action is concerned, I feel like that's a good summary. But basically, it causes the release of acetylcholine and inhibits cholinesterase, and then this acts as a depolarizing neuromuscular blocker, and then this ultimately causes paralysis in the worm or the helminth. So kind of take home point, paralyzes the worm. Adverse effects, notice too, usually pretty well tolerated. Mainly concerned about the CNS adverse effects and GI adverse effects. So those are the two you can remember there. No box warnings, no big things that stick out about this drug. And also too, and kind of related to that, is that these people typically aren't on them long term. Like you guys remember with the TB drugs, they're on it for months. Usually it'll be, a few days, 3-day dosing, 1-day dosing, and then maybe have a repeat of the dosing in a few weeks if it's not effective. And then too, I didn't again link or show you guys the CDC website, but just in general, if you are really interested in worms, now if you're interested in, or if you have patients that are having problems with worm infections, again, CDC's great website, great resources as far as dosing guidelines, recommendations, etc. So this is an older worm medication, just there for historical context. Don't pay attention or don't stress about this medication. It's chemically related to, well, it's an older one, and it's chemically related to some of the older antipsychotics, which we'll talk about more in the psychiatric module later this next summer. So just don't stress about that. Ivermectin, this one is still around. They make a topical preparation of this, as well as a systemic, so you can give it PO or use it topically. And as far as it being available topically and by mouth, or so that it is primarily used by mouth for worm infections, so it is an antihelminic. It does have an off-label use, the oral medication for lice and for scabies, but then the topical preparation of ivermectin is indicated for head lice, and then also it's used for rosacea. So a little bit different there on the uses, but so you can go ahead and add that there. So as far as the mechanism of action is concerned, for both topical and systemic, the medication binds selectively and with strong affinity to glutamate-gated chloride ion channels, which occur in the nerve and muscle cells of the worms. And then this leads to increased permeability of cell membranes to chloride ions, then hyperpolarization of the nerve or muscle cell, and then ultimately death of the parasite. So I think this is a pretty good summary here, but just know that it will end up killing the parasite, and it's basically because of that increased permeability of the cell membrane. Uses, couple uses there, know those. Adverse effects, usually well tolerated, not big box warnings or contraindications here. As far as common adverse reactions, you can think of them as being dermatologic, so pruritus or the itchiness, other dermatological reactions like a rash maybe, hematological, there's some of those also so related to the lymph node enlargement, neuromuscular and skeletal, so arthralgia, muscle pain, etc. And then fever is one of those ones it's kind of a miscellaneous adverse effect, but it can occur in up to 23% of patients that take this, and it's just one of those that is something to monitor and definitely treat, but can unfortunately be an adverse effect of this medication. Having said that too, it's typically, again, something that you're not on long term, so a lot of times it's a one-time dose or maybe a couple doses, and then it'll be something that you repeat in a few months, depending on the specific indication or whatever. So you don't have to worry too much about long-term exposure with as far as adverse effects go. The reason I noted the fever too, because when people aren't feeling well or whatever, it's just something that you don't want to start chasing or start maybe diagnosing something else, and make sure you think about this drug that can actually maybe cause the fever, and definitely treat it. I mean, don't leave it untreated, especially depending on how high it goes. You guys will learn about cutoffs of fever and when you give antipyretic medications or fever breaking medications. But anyways, interesting. Summary table, also interesting. No, please pay attention to this. Look at these drugs here. Clinical applications, adverse effects, contraindications. Antifungal. So this is where I kept saying this is not an azole, this is not an azole. So there's azole antifungals, which we're going to start with first, and those all end in the azole. So for example, mebendazole, which we just talked about, is an anti-helminth, or it's a worm medication, is not an azole antifungal. Metronidazole is another one we talked about. You guys remember that one? That's an antibiotic that can be used for anaerobic infections like C. diff, right? That is not an azole. So I believe I mentioned to you guys before, but they have sound-alike, look-alike medications in pharmacies, or in pharmacology in general. And it's something that students and practitioners, I mean, this unfortunately happens with medication errors where people will pull wrong medications, or they'll write for the wrong medication, or will dispense, as pharmacists, we will dispense the wrong medication because the drug names are so similar. So I've had students in the past make some mistakes and get kind of tripped up on those. So please pay attention to categorization, please, please, please. Okay, so azole antifungals, it's a very popular class. You'll probably be seeing those and coming across those and prescribing those yourself. Big list here, topical oral IV. So students always in the past ask, do we have to know which one's topical? For my testing purposes, I'm not going to have you guys memorize if it's oral, IV, topical. But it's definitely something it's good to know. And you do notice there have been some other preparations like the Ivermectin. I mean, I mentioned that it's topical and systemic. It will definitely be beneficial once you're on rotations and once you're out in practice. But for my test, it's just more of, I'm going to give it to you. I think it's important for you to learn, but I don't want you guys just doing that rogue memorization right now. I feel like there's enough of memorization. I want you guys to get the categories down. I want you to know where these fit, as far as what they're used for. So these are for fungal infections, right? Antifungal. So hopefully that relieves your burden a little bit. I know you still guys have a ton of stuff to do, but I'm trying to, even though it may not seem like it sometimes, I am trying to make this as focused as possible. Kinetics, they are, some are PO, so they are well absorbed. This is just kind of FYI. Fluconazole can hit the CNS, can cross the blood-brain barrier, may be good. The clearance there, this may affect, which ones you choose or which ones you prescribe, depending on the patient's renal status or hepatic clearance, but or their liver status. But this slide here is just kind of FYI. Don't stress about that. Mechanism of action. This is a good slide. So interesting that these actually azoles. So this is for the whole class. Again, you can make a generalization when you're studying and learning mechanism of action. But so the mechanism of action, it interferes with fungal cytochrome P450, which is interesting. So it interferes with that activity, and it actually causes a decrease in ergosterol synthesis, which is a important component of the fungal cell membrane. So it's a building block of their cell membrane. And then because of that, it inhibits the formation or proper formation of the cell membrane. So basically you can think of it like with some of the antibiotics that affected cell wall membrane, that definitely remember that it inhibits the ergosterol synthesis, and that it inhibits fungal cell membrane. So take-home points there. And then here's a visualization of that if you want one, but it just shows that that some of the other antifungals do other things. But here's the azoles, is what we're talking about. But basically, again, hits that ergosterol, and then you don't have a proper fungal cell membrane, which is important because then that doesn't support proper life, right? So it helps kill the fungus. Its uses, I've talked about these already in a previous one, but they are antifungals, so they're for fungal infections. So this is where here's the proper name or the medical term, and then I put here what the lay public will use. So a lot of times your patients will come to you talking about athlete's foot, jock itch, ringworm, and that's what I was saying. I made the point earlier that you need to educate your patients that these are all fungal infections, and that there's good and bad things for fungal infections as far as you can help spread them, or you can help contain them and then treat them. So one tip that I usually pass along patients when they come to me in the pharmacy is that athlete's foot can become jock itch, so it can move. Right, so if a person has a really bad case of athlete's foot, and with fungal infections in general, you can spread them to different parts of your body. So definitely important as far as patient education, and then something we talk about in the pharmacy with our patients. So, for example, put your socks on, put your antifungal medication, put your socks on, and then put your underwear on, so that you, because unfortunately sometimes the underwear or can move, or you can just help, it can help move the fungal infections around. So same thing with ringworm, it can be spread to other parts of the body, etc. So, and then it's a myth too that you only get ringworm for animals, and I don't know if this is a common myth, but I've come across this in the pharmacy, where they're like, oh, I can't have ringworm because I don't have any pets. So you can get fungal infections even if you don't have pets. So that's another thing too. There's going to be, you're going to learn throughout PA school. There's a lot of mythology, I guess, or old wives' tales, or there's a lot of misinformation, I guess. I'm not trying to be disrespectful to the lay public. I mean, I was lay once, right? I was lay public, right? Yeah. So, anyways, just that's something else to note with that I've come across. Systemic treatment too. So we mentioned topical, but systemic treatment as well. So I'll let you guys read through that. Meningitis, we mentioned the fluconazole does cross the blood-brain barrier, so that's where it can be advantageous if you're trying to get to the brain. Aspergillus, you notice just itraconazole there. Okay, and I'm sorry about that. A little edit there. Aspergillus is for itraconazole and voriconazole. So please note that there was, it wasn't an error, but it looked weird. But so yeah, please note that both of these can hit the Aspergillus, which is important to note. Adverse effects here, again, for the class, you need to be thinking about the liver. So there are hepatic adverse reactions potentially. So hepatitis, increased serum alkaline phosphatase, increased serum ALT and serum AST, and then jaundice are all things you have to think about. You don't need to make dosing adjustments for hepatic impairment, but it is an adverse effect you have to be concerned with. Other than that, too, it's not listed here, but GI adverse effects, so nausea, abdominal pain. And you'll notice that with a lot of these antimicrobials, I've been saying GI, it's just something that, hopefully will be started kind of making a broad generalization. So it's like the same thing with the anticoagulation presentation. Bleeding is a big kind of umbrella adverse effect you need to be concerned with those medications, right? So with the antimicrobials, GI is one, and then headache too. Headache's another one that's not on here, but headache's one that can happen up to 13% of patients that take that. The gynecomastia is interesting. It's a rare one. It's because it does block the adrenal steroid synthesis, and so that's something it's not common. It's one of those rare, but I don't know if serious is the right word, but rare but concerning, or something that people don't like to have happen to them. Another rare but serious adverse effect that's not on here is prolongation of QT interval. And let me go. Let's just add that right now. Okay, again, that's a rare but serious one. So you may have some changes on the ECG or EKG, and then there's implications for arrhythmias. So it is one of those, and this is one that part of these I added to the slide. It is one that you'll see, and it is kind of a class effect that for board questions, etc. But QT prolongation potentially leading to torsade de points, which you guys will learn about, is a specific type of EKG presentation where it looks like a twisting of the points. I believe it's French for twisting the points, but basically because of that QT prolongation, increased risks for arrhythmias. So definitely you need to use caution with patients who have a history of arrhythmias, or if they're on other medications that can cause arrhythmias. So this is one for drug interactions that you get a lot of flags on, so to speak, or you get a lot of highlights on drug interactions. Another reason that the drug interactions are a big issue, and again, want you to have this stereotype for the whole class, is that the azoles inhibit cytochrome P450, so drug interactions definitely need to be thinking about, especially ketoconazole, but it's for the whole class. So anytime you see an azole antifungal, be thinking about that, or if you're thinking about prescribing it or initiating it, I want you guys to have the association with drug interactions. Usually not a huge deal, so I come across this a lot in the pharmacy, and my recommendation for management is, so you as a prescriber, a person has a fungal infection, you want to prescribe them fluconazole, let's say, and then they're on a statin, they're on a cholesterol medication, which we'll talk about in the cardiology module. And so a a cholesterol lowering medication like a statin is for a chronic issue, where a fungal infection is for an acute issue. So typically what we'll recommend, or I'll recommend if you guys ask me, or if or you guys, or maybe you guys be awesome practitioners and won't need my advice in the future. But so what you can do is you can temporarily discontinue the cholesterol lowering medication. So they're going to be on antifungal for 3 days, 7 days, whatever it is. Go ahead and hold their cholesterol medication, because really there's a long-term benefit for being on a cholesterol medication. It's not going to kill you to be off of it for 3 days or 7 days. And again, because of the drug interaction, it's important to treat the fungal infection, let's say, and then go on that. But so definitely want you guys to remember drug interactions for the azoles. And the other thing too is I talked about the hepatic impairment concerns, that you don't need to necessarily do dosage adjustments, but it is something you want to use in caution when people have pre-existing hepatic impairment, and it may be a rationale, or especially if you're going to be on longer term, to monitor their liver function. The other thing to note too is that you do need to be concerned about renal impairment. So you need to be cautious with patients that have renal impairment when you're prescribing these azoles, and that these medications do need to be dose adjusted if there is renal impairment. So no dosage adjustments for hepatic impairment, even though they can cause hepatotoxicity, but you do need to make dosage adjustments based on renal impairment. Okay, and it seemed like I spent a lot of time on this, and it seems like a ton of information. Again, these are popular medication antifungals that you guys probably will be coming across on rotations and then out in practice. Amphotericin B, which the pharmacist joke is this is amphoterrible B, and hopefully I'll kind of illustrate why it's called amphoterrible. But and please hold your laughter. I know it's in a hilarious joke. But yeah, so amphoterrible. I don't know if that's going to help you guys. That's always stuck out. Pharmacists would tell me that, and that's always helped me kind of remember this drug and remember the name. But amphotericin B. Just a quick note. So you notice it says Pauline antibiotic, which can be confusing. So I put that there because you may see that sometimes, or you may see Pauline antimycotic, but amphotericin B is part of a class of antimicrobial Pauline compounds that target fungi. So anyway, so that's why that's there. And so amphotericin B, nystatin, and anatomycin are example of these Pauline antimycotics or Pauline antibiotics. So it's more for classification, but don't worry about it for my test. You can kind of black that out if you want. I found that it's just been confusing in the past for students, but it is an antimycotic or an antifungal. So antimycotic, by the way, too, I don't think I've used that term before. That's synonymous with antifungal. So they can be used interchangeably. And again, depending on what textbooks you look at, depending on what pharmacology books or whatever sources you're looking at, you may see that. So I had put it there because it's something we're taught in pharmacy school, and it's just something that maybe can help with classification, but anyways, just so if you want to keep it there, it's Pauline antimycotics is maybe more, but don't think of this as an antibacterial. It is antifungal. And then to make matters even more confusing, these were actually derived, and they're a subgroup from of macrolides. So again, you may see that in other, but please just scratch all that. Students have had problems in the past and gotten confused. For my test purposes, this is an antimycotic, which is an antifungal. So it's amphotericin B is a antifungal medication. The kinetics here, just read through it. That's just more FYI as far as how it's administered and everything. Mechanism of action, it binds to the ergosterol, altering cell membrane permeability in susceptible fungi, and then it causes a leakage of cell components with subsequent cell death. They also think that it's part of the not fully elucidated mechanism of action is that it also causes an oxidation-dependent stimulation of the macrophages. But don't worry about that. Take-home point for my testing purposes, it increases cell permeability, so therefore you have leakage of cell components, and that causes cell death. Okay, so uses. This is typically not a first-line medication, so it's actually the literature says that should be used for, quote, life-threatening fungal infections. So it's something that should not just be done, for everybody you kind of come across and with a fungal infection. And it's also related to a box warning. The FDA box warning has, again, quote unquote, appropriate use. So this drug should be used primarily for the treatment of patients with progressive and potentially life-threatening fungal infections. It should not be used to treat non-invasive forms of fungal disease such as oral thrush, vaginal candidiasis, or esophageal candidiasis in patients with normal neutrophil counts. So again, I have some uses listed here. I want you guys to know what it's used, but definitely it's that, you notice I said life-threatening twice. So yeah, and again, it's related to a box warning, so please note that. The other box warning is as far as is concerned with error prevention. So this is more in when it's actually being administered, and this is more in dealing with inpatient use, but it just basically reads that exercise caution to prevent inadvertent overdose with amphotericin B. There's unfortunately been issues with overdosing in some of the way that it's supplied and administered in the hospital, and that the FDA wants you to verify the product name and dosage if dose exceeds 1.5 milligrams per kilogram, which my experience, amphotericin B in the hospital, there's protocols for it. Again, it's for life-threatening one. It's probably by seasoned practitioners. It's not just laying around all over the place or whatever. But anyways, and that's why it's ampho terrible. No, and this is why it's ampho terrible. Adverse effects. So you'll notice a lot of bad adverse effects. I went ahead and here listed it's potentially life-threatening fungal infections. This is part of the reason too that it should be reserved and not first line because of the bad adverse effects. Oh, and you can it kills the kidneys, it kills the liver, it has hematological, it can cause anemia, and then fever and chills, kind of miscellaneous there. People don't like that when they're given it. Makes them feel worse usually before they feel better. But very toxic medication. So again, ampho terrible. Hopefully that help you remember. But nephrotoxic and hepatotoxic, so kidneys and the liver. Flucytosine, this is another strong antifungal medication. Kinetics, don't worry about that too much. As far as mechanism of action is concerned, it penetrates fungal cells and is converted to fluorouracil, and that is an antimetabolite, but that competes with uracil interfering with fungal RNA and protein synthesis. So take-home point, it disrupts fungal RNA and protein synthesis and results in the death of a fungus. Uses. So again, this is something that's not typically first line. It is something that's, there is problems with resistance, unfortunately. It is used in combination with amphotericin B. So you can think of this as an adjunctive treatment, and it's going to be used with other things. Adverse effects, we have some GI adverse effects. We also have the bone marrow suppression, which we have to be concerned with. There's also a boxed warning on here that this should be used in extreme caution with patients with a renal impairment, and that there requires close monitoring of hematological, renal, and hepatic status of all patients. And it says that is quote unquote essential when administering this. So again, you have to be thinking about it can be toxic to the kidneys, toxic to the liver. So again, not first line, typically adjunctive, and it is going to be a messy thing. So inpatient use primarily, and then again, the box warning recommends close monitoring of the patient. So we have the echinocandin antifungal drugs, which are a newer group of drugs. Please note, I just corrected, this is beta, it's not F3 or whatever. Sorry, stupid conversion. But we have a list of those here. You'll notice the caspofungin has prototype in parentheses. That just means that was the first one of this new class that was developed. So it's the older one of it. So mechanism of action here, it's pretty interesting, in that it inhibits the beta 1,3 D-glucan, which basically is a important building block of the cell wall of susceptible fungi. So you basically cannot have a proper cell wall developed, is the take-home point of that, and that it mainly works against active cell growth. So it's for the actively growing fungal infections. And then the good thing too about the mechanism of action, this is related to its toxicity and adverse effects, is that mammalian cells, which we are mammalians, we are mammals, right? Spoiler alert. No, I'm kidding. Mammalian cells do not require this beta 1,3D glucan. So it is very specifically targeting the fungus, and it should not adversely affect our cells, which is good, right? Yay us. Uses. So usually reserved for more severe, so aspergillus, an invasive aspergillus, candidemia, or you have a fungal blood infection, esophageal candidiasis maybe, and then the empirical treatment of presumed fungal infections in febrile and neutropenic patients. And this is just reserved for patients that are 3 months or older, so not for newborns. Adverse effects there, you can note that the cardiovascular adverse effects are pretty common, unfortunately. So the hypertension can be up to 20% of patients that are taking it. Peripheral edema, another cardiovascular effect, up to 11%. Tachycardia, also up to 11%. As far as CNS adverse effects are concerned, there are chills, which can be up to 23%. Headache, up to 15%, and then the rash too, unfortunately, can be up to 23% of patients that take it. So GI adverse effects as well. It's not listed here, but again, kind of just something you can think about with a lot of these antimicrobials. But so things like diarrhea, vomiting, nausea. Unfortunately, anemia can be a concern too with these, and hypokalemia is another one. One that's not on here too is there are potential for hepatic adverse effects. So increased serum ALT, increased serum AST, increased serum bilirubin, and increased serum alkaline phosphatase. So potential liver toxicity too. And on top of that, renal implications. There can increase serum creatinine up to 11% of patients that take this. And so then as far as dosing implications are concerned, there are no dosing adjustments needed for renal impairment, but then there are some recommended dosing adjustments for hepatic impairment. Griseofulvin, so just read through the kinetics as usual. Don't stress too much about those. Mechanism of action, it basically inhibits fungal cell mitosis at metaphase. So that is the take-home point of that, which is M phase. M phase stands for the is the same thing as a metaphase. So inhibits fungal cell mitosis at metaphase. Its use here, susceptible infections. So dermatophyte infections is what you can classify them as. So skin infections, right? Skin, hair, nails. Adverse effects, read through those. Some are more severe than others. The hematologic effects are the rare but serious ones. There can be some hepatotoxicity you have to be concerned with. So jaundice and elevated liver function tests or bilirubin. And so they do recommend, if there is an elevation in the AST, ALT, or if there is signs of hepatic dysfunction, to discontinue therapy. Interesting here with penicillin allergies. So because of the chemical structure of this, there is a potential for, if a person has a true penicillin allergy, to have a hypersensitivity cross reaction with this medication. But it is very rare, and it is one of those that's more of a theoretical concern than something that has. There's basically been evidence shown where people who have a penicillin sensitive or penicillin sensitive patients have taken this medication without the reaction. Photosensitivity is another one that, again, just recommend sunscreen, staying covered up. And then skin reactions, it's a severe, so it says rash here, but You can have a severe skin reactions with this. Again, rare but serious. So Stevens-Johnson syndrome is a potential concern here. Now we have the allylamine antifungal drugs. 3 examples there. You notice a couple topical, one topical and systemic. Kinetics, don't worry about that. Just read through that. Mechanism of action. So it inhibits squalene epoxidase, which is an enzyme in sterile biosynthesis in the fungi. So this results in a deficiency in ergosterol within the fungal cell wall and then results in fungal cell death. So it's kind of like the azoles, that's why I put that here, but a little bit different. So take-home point, it basically affects sterol, and then it causes deficiency in the ergosterol, and there's not a proper cell wall that's formed for the fungus, and then it causes it death. Some uses there, just read through those. Adverse reactions, pretty well tolerated. Most common are headache, up to 13%, and then GI upset, just like with everything else. Nystatin, interesting in that it is, I mentioned it's similar to amphotericin B as far as how it's used, but it is not absorbed from the GI tract. So there is not systemic exposure, so it's a way better tolerated. It's not as toxic as the amphotericin B. And so you don't have to be as concerned about the adverse effects with nystatin, even though it is related or kind of a cousin of amphotericin B. So it's like a much nicer cousin. It's not your cousin who's been to jail right now. Amphotericin B is, I'm kidding. Just talking about my family drama now here. But it is a lot less toxic, and you don't have to worry about that. They do make topical preparation, so it is good for topical fungal infections. And then the other benefit of it too is that it's not absorbed, so that it's good for intestinal fungal infections. Tolnaftonate, this one, over-the-counter product. Tufactin, Tinactin. I don't know if you guys remember those commercials. Probably before you guys were born or were in diapers, or whatever. But Tinactin is the over-the-counter brand, so this is used. This is one that have topical treatments. They make sprays, creams, different things over the counter, different topical preparation, not different things. Sorry, different topical preparations for ringworm, jock itch, athlete's foot. And then as far as mechanism of action, this is as simple as you can get it. It just distorts the hyphae structures. It stunts the mycelia growth of the fungi. So it basically, doesn't allow proper growth of the fungi. All right, so that's great table here with all the antifungals. So definitely look at those. I spent some more time on some of the adverse effects of the azole, so please note those and add those to this table. And then go through the rest of them too. Check out the clinical applications, adverse effects, and contraindications. And here's some more too. So go through all of those, please. And that's it for me today. So thank you all for your time and attention. And I will be talking to you guys later. Please feel free to email me if you have any questions. Have a good day. Bye.